Thank you so much for joining us this week. As always, we're going to just take a moment to kind of let the room fill up a little bit more before we go ahead and get started. Hi, everyone. We're going to just continue to take a moment and let the room continue to fill up before we get started. Okay, well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on raising the bar for joint health. My name is Alson Murtha, and I am the moderator of this series. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. If you're joining us from one of our live streaming platforms, as always, you can comment your questions in the comments. We have staff members monitoring these questions, which we will post to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, April 14th. I am joined today by Dr. Annette von Drygalski. Thank you for taking the time to join us today. I will go ahead and turn it over to you to get us started.
Thank you, Allison. It's my pleasure today to talk about raising the bar for joint health, and we will look at that from multiple angles. These are disclaimers. So, objectives. Let's discuss today joint disease epidemiology, pathophysiology, and provide an increased understanding of subclinical microbleeds. I have to disclose, I don't like the word microbleeds much, but let's just say subclinical bleeds. We don't have a good definition for what micro means. Then let's review the current standard of care for assessing joint health, particularly focusing on the advantages and disadvantages of imaging techniques. Something that comes to mind here is, of course, musculoskeletal ultrasound and those techniques to be used to identify early joint damage. And then we review the relationship between factor levels and joint health in people with hemophilia on prophylaxis. So let's talk about joint bleeds. Obviously, we have to encounter joint bleeds in hemophilia, unfortunately, and that secondly goes or translates into joint health burden in hemophilia. Now, how do we assess joint health in people with hemophilia, and how do we progress in that area? And then come to point of care ultrasound imaging. As we all know, joint bleeds may lead to acute and also chronic pain, and that can carry a substantial burden. Turns out that 50% of persons with hemophilia report experiencing acute pain in the past 6 months, whereby the onset of bleeds here is characterized by patients as swelling, pain, and loss of range of motion. And no surprise that almost half of people with hemophilia report living with chronic pain. And of course, logically, the prevalence increases with disease severity and age. So in adulthood, that can become quite a problem. And chronic pain is associated with a reduced quality of life that encompasses restrictions in mobility, difficulties with relationships, limitations in daily activities, poor mental health, reduced work and perhaps school productivity, and unfortunately, very often opioid dependence. So how do we know when joint pain is due to a bleed? I think over the past decade or so, that has become paramount because without objective evidence, we really don't objectively treat well. And this is because pain symptoms and findings are non-specific. If you look here at a number of conditions from hemophilic arthropathy to gouty arthritis, rheumatoid arthritis, reactive arthritis, osteoarthritis, and I think many of us don't even know anymore what Charcot arthropathy is. But all these arthritic conditions present with swelling, redness, loss of range of motion, pain, warmth. It's really non-specific to hemophilic arthropathy. And what do we lose in terms of treatment if we don't make an accurate diagnosis of what's going on in the joint? So what is the best tool to detect acute bleeds in clinic? Distinguishing bloody versus non-bloody effusions, let alone just arthritic pains, might be challenging. So we sort of understand right now that patient perception and even physicians' clinical exams are not very good in terms of diagnosing pains associated with bleeds. There are somewhat unreliable methods. So in terms of imaging, we do have X-rays, but they cannot really detect bleeds. They are very insensitive to bleeds, to soft tissue changes. They can assess joint deterioration as it comes to cartilage and to bone health, but really not much more. It also involves the radiation, although the radiation of an X-ray is really low. Then there are CT scans that can show bleeding, but it involves quite some radiation, and so that shouldn't be done very often to a joint. The MRI is considered the most sensitive measure for joint assessments. It provides detailed joint imaging, not just bony and cartilage changes, but also soft tissue changes, synovial changes. But it is time consuming, there is limited accessibility and cost. And something we will see in a little while throughout the slides is that it's actually not very good to distinguish bloody from non-bloody effusion, something that's not really appreciated very well, but I'll show you the evidence for that. And then we have musculoskeletal ultrasound, which really has shown to be able to detect blood at low concentrations and at low volumes. Volumes meaning just a little bit above normal joint fluid volume. It can distinguish bloody versus non-bloody effusions relatively easily, and it is very quick, on the order of minutes, and can be done in clinic. Of course, the technique is operator dependent, and your physicians or physical therapists or whoever is at the center needs to have some training to perform this. So musculoskeletal ultrasound uses echoes, and these echoes are reflected by tissue structures to create an image. And on the left here, you see just a cartoon of the knee joint. And to the right, you see the image that's produced by an ultrasound. And that's, by the way, my knee. And you can see how anatomically precise an ultrasound image is, and it can be obtained within seconds of holding a transducer to the knee joint. So here you would have the patella, that's here. This is the patella tendon going into the patella. That would be this part here. Then you have the suprapatellar bursa, or one of the recesses that connects to the joint space with a little bit of fluid in here. This would be the dark stuff here. This is cartilage over the femur, and that is the so-called interface sign that replaces or that distinguishes or separates the cartilage from the fluid, because they both are here hypoechoic. And you can see here, this is a minuscule amount of fluid in my joint. It's completely physiological, nothing problematic about it, yet the ultrasound can really capture that. So ultrasound can distinguish bloody from serous. We say serous, or just normal effusions without blood. So this would be a serous, what we call simple effusion. You can see the fluid is just black, as was my joint fluid in the previous image. And then this is an acute complex effusion in the context of hemophilia. We call that hypoechoic with speckles. These are bloody red cells, so to speak, blood and red cells in the effusion. They serve as reflectors and therefore create echo, and is easily distinguishable. Muscas has high sensitivity for blood detection, and that's shown in this research study here. Think about a syringe. So a syringe was filled with saline, plasma, joint fluid, or here 100% blood. And you can see that saline, plasma, and joint fluid are really anechoic black. These are some artifact speckles of non-resolved hyaluronic acid. And these are some air bubbles while handling the joint fluid, but this here is 100% blood. And blood, therefore, again, is highly echogenic and can be easily distinguished from saline or plasma. Moreover, concentrations as low as 5% of blood in the joint fluid can be detected with ultrasound. And so this is a compression movie to show what a real bleed or fluid in the joint looks. We apply compression, and then you can see that these joint spaces are compressible. And here you see an effusion that's maybe already a few days old. You see it's speckled. It has maybe fibrin strands in there. It's really complex and only partially compressible because the patient has already infused clotting factor. So now I'm showing you the evidence that ultrasound is better than MRI to distinguish joint bleeds. So the top row here has a patient with anechoic serous fluid in the suprapatellar bursa and in one of the recesses, compared to this patient here below in the lower row. This is a bloody effusion. You clearly see the speckles. Both patients came in with acute pain, both hemophilia patients, to clinic. They were aspirated, so is aspiration proven that one had a joint bleed here speckled and one had just a serous effusion? I think it's pretty clear from the visual. But then you look at the MRI, was done the same day, and independent of T2 or T1 weighing, it is, I think, quite clear that the MRI looks this and this and this and this, looks very comparable. So it cannot distinguish, providing different signal intensities if this is a bleed or not a bleed. It's just fluid in the joint. So point of care musculoskeletal ultrasound can also be used for longitudinal evaluation. We love to use it in clinic for just a quick, is it a bleed or not? But clearly it can be used for many other purposes. It can detect early joint damage and can also monitor, therefore, long-term changes in joint health. And these are examples of some studies to show that the proportion of asymptomatic joints with signs of joint damage can be captured by ultrasound in terms of synovial hypertrophy and cartilage erosion. So again, before the patient even notices there are problems. And the same here in this study, the proportion of joints with subclinical synovial hypertrophy, meaning there is synovial progression, but patient wouldn't notice anything yet. And this is patients without joint symptoms. And then at some point, of course, people do get joint symptoms. There are two protocols to show or pick up early changes or also later changes on ultrasound in all different domains, cartilage, osteochondral, and synovial. One is the HeadUS protocol. It complements physical examination. It is a scoring protocol and therefore encounters ceiling effects. It's just semi-quantitatively providing an idea and a score of what's going on in the joint. It does correlate with hemophilia joint health scores to some extent, and it does have some reliability in terms of different readers finding different things. Again, it is but somewhat subjective and relies on pattern recognition, but I'll take you through it in a bit of detail. So this is looking into the femoral patellar joint space, and here you see a pristine osteochondral surface, and that is lined by cartilage. That's that black area here, and then on top is the suprapatellar tendon. And so as you can see, so these pathological pictures with the protocol, it is sort of a sum of the extent, severity of joint changes, and then how much of the joint space is affected, and the reader comes up with a score. In the interest of time, I will just move forward and go to the next protocol, and that is the JADE ultrasound protocol. That is a fully validated protocol. It is objective in that it relies on measurements. It has no ceiling effects, and versus the HeadUS protocol is maybe better for early joint changes, a little difficult to evaluate later joint changes. This here allows for joint changes throughout all stages of arthropathy. And you can see here quantitatively, we can measure osteochondral alterations, we can measure cartilage thickness, and we can measure here synovial proliferation. And in addition, the JADE protocol has a measure or an assessment of vascularity, synovitis, abnormal inflammation in the joint that can be assessed. and there is excellent inter-rater reliability. Clear because it's just objective. One applies a measurement. It's a little easier to perform than pattern recognition. And again, in the interest of time, I will move on here. So I think I hopefully have convinced you that point of care musculoskeletal ultrasound supports clinical management in hemophilia. It's fast, it's accessible, especially now that we have handheld devices in clinic or the access to it. There is no more need for large costly equipment. It's sensitive, it can detect acute bleeds, identify early and also later joint problems, and monitor disease progression. It really takes only a few minutes per joint. It can be used for young children. There's no sedation necessary. It's widely available, has low costs, and and this is important because you can do that easily with X-ray, detect soft tissue changes quite easily. And perhaps in the long run might provide insights on treatment efficacy, although there are no data created yet that would suggest that using the ultrasound in clinic to monitor changes and then change the treatment paradigm thereof would really portend better outcomes. That's a disclaimer to say. It can be used for all joints actually, but in hemophilia, we look at elbows, knees, and ankles, of course. It correlates well with MRI and hemophilia joint health score findings. And there are several standardized simplified scanning protocols like the HeadUS or the JADE protocol available, and they can be, that's the idea, conducted and performed by non-radiologists. Okay, and then we have new studies and exciting things ongoing where patients can even participate in self-imaging. They can take home a small ultrasound device that they can plug into the iPhone and then via telemedicine, maybe do a quick joint assessment and get advice without even having to leave home, house, or school or work. So now we move on to joint health outcomes in hemophilia. Now that we know how to assess it or what the future holds in terms of assessments, let's go to joint health outcomes. So first we will talk about joint health in the era of prophylaxis, then importantly about the relationship or what we know currently between factor levels and joint health. And so let's take a step back and look just at the definitions of prophylaxis. So joint health goals differ across factor replacement therapy protocols, of course, and we call it primary prophylaxis if prophylaxis is started very early in life as a toddler before the second joint bleed. And the idea is here, start early and reach normal joint health or aim for normal joint health once you reach adulthood or early adulthood. Secondary prophylaxis starts a little later, maybe at school age, 5 to 10 years, and per definition is sort of after the second joint bleed. It's not perfect, but it's supposed to maximize long-term function of the joint. And then tertiary is if prophylaxis is started, unfortunately, when the damage is done already as an adolescent or adulthood. And here we can just hope to slow joint disease progression, minimize pain, prevent further bleeding, and hopefully thereby improve quality of life. And then episodic treatment is really not the standard of care anymore. That means just chasing bleeds. That would be more for moderate or mild hemophilia, but certainly not for severe hemophilia. In studies, overall, prophylaxis reduced joint damage more than on-demand treatment. And I mean, we all realize, and this is not shown here, the joint health outcome study of Marilyn Manco Johnson, which was done in the mid-2000s to show that in little children who received prophylaxis versus on-demand, there was true proof. Not only did it reduce joint bleeding, but it also reduced joint damage measured by MRI. And so here are other studies performed a little later to show that the same is true in adolescents and in adults and as adolescents and older children. And here is one study showing clearly that the hemarthrosis per patients, go up if patients are on demand. You can see here 40 hemarthrosis per patient or so compared to 14 per 7 if patients are on demand. But not only that, on prophylaxis, I apologize, but not only that, this correlates with worse radiographic outcomes. So yes, you have more joint bleeds, but what insurances at least 10 or 15 years ago wanted to see, something that we forget, is this really related to worse joint outcomes? And the answer is yes. So back then it was still radiographic and mostly Pedersen scores. And here the same, these were adults, and then here we have the same study or something similar performed in younger children and in older children, and clearly on demand only, there's lots of joint bleeds compared to being on prophylaxis. And again, the outcomes are worse, and that's the point. So in studies, children and adult patients with severe hemophilia receiving primary and secondary short half-life products at the time, then it was still conventional and short half-life clotting factor preparations, experienced significantly fewer joint bleeds compared to on demand. So now we come to, okay, we understand folks have to be on prophylaxis, but how early should they really start? And the thought is the earlier, the better. And there are several studies to show that this is really true, that the risk of joint damage is lower in those receiving early versus delayed prophylaxis. But, and that is really important, some patients still exhibit joint damage despite receiving early prophylaxis. It's not perfect. And that is shown here to the right in that graph, which here is sort of an extension of the Manco-Johnson joint health outcome study I showed previously. So once these kids were studied and it was clear that those on demand had much worse outcome than those of prophylaxis, those on demand were also started on prophylaxis. And then 15 years later or 20 years later or so, there was a second look. So how did the groups prepare? One group got early prophylaxis and one group was started later. And you can see clearly that those with delayed prophylaxis, many of them, 77%, had joint damage compared to those on early prophylaxis. It's sort of logical. But what strikes here is that even on early prophylaxis, 35% of patients had joint damage when entering adulthood or early adulthood. So please keep that in mind. That's more than a third. So meaning prophylaxis as we do it currently, and this is again with conventional short half-life preparations, is unfortunately not perfect. Makes things better, but it's not perfect. And that is depicted here. So now we, I think, understand that prophylaxis may not fully prevent joint damage, and there's just more data to show that progression of joint arthropathy during intensive prophylaxis regimens. And as you can see, this all dates back 10, 20, 30 years here on the x-axis, showing the course over 30 years. So we talk about not very modern prophylaxis, but just prophylaxis, that it's like a self-fulfilling prophecy here that early, let's say below age 10 or so, there is some, very little in terms of joint damage. But then even on prophylaxis, it becomes a self-fulfilling prophecy. So these are Pedersen scores for ankles once patients age, for knees and for elbows, and they become pathologic because everything that's above 2 here is considered pathologic. And below are Gilbert scores that we really don't use anymore. We now use hemophilia joint health scores. So why I'm saying this, still, the risk of joint damage is lowest in patients receiving primary prophylaxis, as we have seen on the previous slide, versus secondary or tertiary prophylaxis. But to that depiction here, once joint damage has occurred, it will progress despite the use of prophylaxis. And so clinical and subclinical joint bleeds continue to occur despite regular prophylaxis, and patients remain at risk of ongoing joint damage and hemophilic arthropathy. So we still have work. This is better than episodic, clearly, but we still have work ahead of us. So now we come to target trough levels. So how can we things make better? And is there any relation in terms of target trough levels that may provide clinical benefit. As many of you know, I suppose there are some patients on this call too. Once you inject medication or clotting factor, you go to a peak level, and then over the course, depending on your factor 8 or factor 9 deficient and how long the half-life of the clotting factor preparation is, but it will decay and you come down to troughs. Then you have to re-inject to come to your peak, and over the next few days, you will come down to your trough. So what is the rationale for higher trough levels? Because that's the day where you are, maybe or someone is at most or the highest risk of having another joint bleed. Clearly, bleed tendencies correlate with factor activity. Historically, and again, it was 20 years ago or 10 years ago, trough levels over 1% were targeted. And that stems from an early study of Peter Collins to say that the risk of bleeding decreases proportionally to the time spent above 1%. But if you're at 2%, you clearly have a much higher risk than if you're at 10% or 20%. That was already part of the study. But historically, everyone said, okay, just being above 1% is fine. So nowadays, I don't think we think that anymore. The 2020 World Federation guidelines of management of hemophilia really state that most physicians now would be in line in terms of target trough levels of 3 to 5%, or maybe even higher. Also, and that is sort of logic, people with target joints usually require much higher factor trough levels to prevent future bleeds, because these joints are vulnerable. They often have synovial hypertrophy, they have fragile vessels. And so, yeah, one might have to think about even higher trough levels to stop the bleeding in target joints. So studies suggest that targeting higher trough levels may really improve bleed rates, and this was a prospective study following patients using not a standard half-life, but an extended half-life preparation, and they split patients in two groups, PK guided. One group was targeted to have trough levels of 1 to 3%, and the other group here in green, and the other group of 8 to 12% here in orange. And then they looked at the proportions of participants with serobleeds in a variety of categories. And I think it's clear from looking at that graph that higher trough levels, than again here in green, in orange, provided improvements in the percentages of participants with serobleeds. So if it's total serobleeds, if it's serospontaneous bleeds, if it's serospontaneous joint bleeds, each time the proportion of patients reaching that goal was higher compared to those with lower trough levels. So that also sets the stage for higher trough levels. And but that was a clinical pharmaceutical sponsored trial, and so patients were very closely observed. So what about what's happening in the real world? And so these are now following two examples when patients switched from a short half-life product to an extended half-life product in terms of prophylaxis. So to the left here is a study from Greece looking at 23 children with severe hemophilia A. They followed them for a few years after switch from a short half-life to an extended half-life prophylaxis regimen. And so they could raise the factor H trough levels to 4.1% on median with the new preparation. Compare that to short half-life prophylaxis, 2.3%. And then with that, the main annual joint bleed rate was reduced quite almost to zero, whereas it was much higher previously with short half-life prophylaxis. Now, interestingly, this group could also reduce the intervals. So not only could they raise the trough levels, they could also reduce the intervals of injections. And with that, 78% of patients had zero joint bleeds, prior 30%. And this is a study from the US, very similar real-world study in hemophilia B. Patients were followed up to 5 years, switched from an episodic or standard half-life product to extended half-life prophylaxis, and the annual bleed rate decreased substantially following the switch. And not only that, almost a third of target joints resolved with that measure. So these were just two examples, but there are several real-world studies really evaluating outcomes following switch to an extended half-life prophylaxis, and they all report improvement in joint health. So higher factor levels provide better protection from joint health, from joint bleeds. So these are predicted joint bleeds in people with hemophilia, with non-severe hemophilia A. And these data were retrieved from a study from the CDC, looking at our data collections. And it's interesting because, again, this is a study with non-severe, because severe, it's always, so what's the best target level, etc. It's always hard to say, because if you look observational at non-severes, they get various factor products, various half-lives, various frequencies. So it's really never catching them in the natural history without any clotting factor prophylaxis anymore, right? So going to non-severes who are not on any prophylaxis, so kind of a pure study group, so to speak, what's the bleed frequency? What's the natural history here? And you can see a couple of interesting things in this graph. So one, the whole population was divided into various age groups, and you can see here that for all age groups, once the clotting factor activity levels reach 20 or 30% in this group, there is almost no bleeds. But then you can see that if it's between 0 and 10%, 0 to 5% is about, we call them moderate, and then anything about 10% is mild. You can see that there is substantial bleeding going on, and this bleeding increases with age. So in the age group of 2 to 9, only maybe one joint bleed per month or per 6 months or so. But then once patients get older, these joint bleeds increase. And so it's not quite clear why that is. Is there perhaps over-reporting? Again, we go back to that initial slide that we don't quite understand when pain is associated with bleeding anymore once we have pre-existing arthritis and patients age. But it could also be true, and it's just people suffer from joint damage very early on, and then it sets them up for more bleeding when they become older. So from that slide, one could take away that spontaneous joint bleeds can occur, although they get less, up to 30 to 35%. So someone who has mild hemophilia is not entirely protected. And then for trough levels of 1 to 10%, each 1% increase in factor VIII level is associated with a 2% increase in patients with 0 bleeds per year. That was sort of a predicament of this study. So from all of these studies, there are now models to suggest that factor VIII levels up to 35% may be required to achieve a near zero joint bleed rate. Of course, this is aspirational, but we can all be aspirational. And that is sort of the predicament now in 2020. And you can see here in 2010, we were still grappling with it above 1% and sort of discussed, well, best would be maybe 15%. But then over the last decade, many more publications came out to suggest, well, maybe the trough levels should be even higher. What would be ideal? And I understand ideal is not always practically accomplishable, but we can be aspirational. So this is another interesting study to say that bleed protection increased with time spent at higher factor levels, sort of recapitulating what was already done with Peter Collins' work almost 15 years ago or so. But in this study, it was a PK-guided study with a short half-life product. It showed that time spent with above 15% level really was optimal, with the option, if one could even increase to 40 to 50%, may be important to protect against hemarthrosis and other bleeding episodes. So with that, we come to this large cartoon, or really busy slide, just to depicting and kind of logic that different factor VIII activity levels may be needed across clinical scenarios and lifestyle. We are now in the area of individualized treatment personalized treatment, and not every shoe fits everyone. So for instance, one can come up with maybe 1 to 3% of a trough level might be fine. If someone lives a sedentary lifestyle and sits at the computer all the time, we don't have to check them up to over 50%. However, once mild physical activity occurs or patients want to go into higher risk activities, doesn't have to be American football, but just being out there playing some ball, maybe climbing, or I don't know, hiking, I should say, or things, maybe it is better to be at 55 to 15%. Even a lot of walking. At a patient last week who walked in SeaWorld for a day. It's not high risk, but it's sort of high impact, and has a bleed despite on regular prophylaxis. So think about, for your patients, once you go up with physical activity, maybe it's more appropriate to rise the factor levels, trough levels. And then, of course, if you come to intense sport activities, you might really need to be higher. And the highest levels we need when we go into surgery, or life-threatening bleeding, of course. So early prophylaxis, we come back to this, okay, we all understand prophylaxis and higher trough levels are better, the more the better, it's kind of obvious, but then again, coming back to early prophylaxis versus later prophylaxis, and start early is the mantra here, because it really may help reduce bleeds and preserve normal joint structure. So prophylaxis is most effective when started at an early age and before the first joint bleed. And this is sort of depicted here to the left, where you see here in early prophylaxis, that was before any joint bleed. These patients over the years, that was a prospective study or an observational study over the years, really shows that there's almost no joint damage. And again, I should come back to, these are all short half-life products, because all these studies date back quite a while and there weren't any extended half-life products available. So it's early compared to late. And really, if you start after one joint bleed or after two to 5 joint bleeds or even more, doesn't make so much difference anymore. So comes back to avoid even the first 1 or 2 joint bleeds. Really early start might be best. And then in addition, to summarize, studies indicate that bleed protection really increases with time spent at higher factor activity levels, and comes back to what's the ideal higher factor activity level and trough level, and what we call area under the curve. Exposure to factor is somewhat debatable, but clearly more would be better. So in summary, people with hemophilia are susceptible to joint bleeds, and that can lead to hemophilic arthropathy, acute and chronic joint pain, and limitation in activities of daily living. MUSCUS, point-of-care musculoskeletal ultrasound, can be used to identify joint bleeds and early joint damage. We should use it in clinic as much as we can. The introduction of prophylaxis led to improvements in joint outcomes for people with hemophilia. However, current prophylaxis does not fully protect against joint damage. So work to do. And here, evidence suggests that higher factor activity levels may provide greater protection against joint bleeds. And the question is how to come to higher factor activity levels. So patients, really important, should consult with their physician to really determine the appropriate target factor levels for their personalized treatment goals, coming back to that really busy slide two or three slides ago. And with that, I would like to thank you for your attention, and I'll be thrilled to take questions and have a debate with you. Thank you.
Wonderful. Thank you so much. Before we go ahead and start the Q&A, as just a reminder, nominations for Awards of Excellence are open through May 5th. We are coming in hot through April, so you have just a couple weeks left. You can head to hemophilia.org/BDC, go to the program tab and click on Awards of Excellence. As a reminder, self-nominations are not allowed at this time, but we look forward to seeing your submissions. I do have a couple questions for you. And I'm going to pull my ones from LinkedIn first because I see the viewer adding a couple more in there. So is it painful when I have a bleed to do US?
No, I don't think so. So I never had any complaints. I can understand what you mean, because it would be the compression that could be painful, but you really need just 1 or 2 compressions. It's like 1 and 2 with the transducer to determine that there's a compressible space. So not really.
Okay. And what is the significance for doing it when a patient is suffering an acute bleed and the joint is swollen?
So first of all, is the joint swelling really due to bleeding or not? I know it's sometimes hard to grasp because every patient or person with hemophilia thinks, well, it must be joint bleeding. But especially in the adult patient, maybe not so much in children, where else could it be if the joint blows up? But in adults, it can have other causes. It could be synovial swelling. It could just be regular good old joint fluid that's not bloody accumulating. So first of all, we can make a precise diagnosis, and not to say someone shouldn't treat themselves with a dose of clotting factor if in doubt. But what do we miss if we always just ascribe everything to bleeding? Because down the line, there can be many other things. It can be gout, patient's age. It can be another musculoskeletal issue like a meniscus tear, or it can be many other things, and we don't diagnose those until we look. Also, the significance would be to aspirate the joint. There are good studies now out to suggest that aspiration and blood removal, if this is blood, makes a difference in terms of pain relief, time to rehabilitation, time to get back to work in school. So consider that. It would also be, here in clinic, we do it ultrasound guided, and it allows to send the fluid for analysis. And I diagnose gout, I diagnose pseudo gout, plus minus bleeding, but now we know the bleeding is not so spontaneous. So maybe it's because there's crystals in the joint and they rub up against the cartilage or synovium. So I hope you get the idea that doing an ultrasound, aspirating, is not to be paternalistic or maternalistic or say, oh, you have a bleed, you don't have a bleed. It's more than that. It's helping with pain relief and helping to make the right diagnosis and fine-tune treatment for joint swelling. Hope that makes sense.
Great, thank you. Another question we have is, how can I get training about muscus?
Oh, yeah. So you can, and I can send Allison this to you. If you go to our UCSD website, put in UCSD muscus hemophilia, or email me. We have a free musculoskeletal ultrasound course at UCSD. It runs several times a year. We made it free from our 340B program income resources for anyone who is a hemophilia provider. And you can book 1 day, 2 days, or 3 days. You can come back and repeat. And we also have a 20-hour online curriculum that's also free and CME accredited. So please email me. I'm happy to send you the links. It's very easy now to get trained.
Wonderful. So another question, what do you think is the reason that older individuals have a higher bleed rate? Is that because of damaged joint structure, or does the bleeding mechanism change with age?
I think I don't have any proof for that, but I think it's simply the progressive arthropathy, the progressive joint damage that makes the joint vulnerable. Number one, like let's say if a little bit of piece of cartilage gets loose and is in the joint space and rubbing up against the synovium or other structures, that might just cause easier bleeding. But also, many patients, or many, have really thickened synovium, and that synovium is often hypervascularized. And there is a component of vascular bleeding that's quite independent from what we just discussed in terms of clotting factor activity levels. So these vessels are fragile. Think about it like the synovium growing like a tumor and having all these aberrant vessels. And with mechanics or for whatever reason, they can burst and then bleed. So it's multifactorial, I think. And to that point, this is where synovial ablation comes in. I think there's still a good number of synovial radiosynovectomies ongoing to remove the synovium and then have some bleed relief, or sometimes embolizations. So here the interventional radiologists would move microcatheters into the synovium and embolize it to just make it die off in order to avoid this kind of vascular continued bleeding, or surgical removal. And that's a real important point, by the way. Sorry for carrying on. But if anyone undergoes a joint replacement, if you're a patient or if you're a physician, you have to educate your surgeon to please remove the synovium. It seems like that's a non-brainer and they should do that automatically, but they don't. Surgeons are very focused, unless they know, to just replace the joint surface. They don't look for removing the synovium, because that is an extensive procedure that can add 2 to 4 hours to their surgical procedure. And unless they have planned for that, they won't do it. So what happens? Bleeding afterwards. And you think, oh, I have a replaced joint. How can this happen? This is because they left hypertrophied vascular synovium behind.
Great, thank you. And what is the biggest takeaway you want the audience to walk away with from your discussion today?
I think we are going into a new era of new clotting factor preparations, of gene therapy, of factorless treatments that all in all will provide higher trough levels, steady state levels, so that we don't even have to talk about peaks and troughs anymore, that exceed what we are used to now. So it will be much easier, hopefully, to provide protection. And while our adult and advanced patients might not get as much benefit anymore as children who start out with pristine joints and may have in the long run the highest benefits, even older patients, I think, will benefit from that by reducing bleed burden and thereby improving quality of life.
Wonderful. Thank you so much. Okay, well, I'd like to thank you once more for taking the time to join us this afternoon. We appreciate your time and expertise. I would also like to thank each one of our viewers for joining us. Please note that this recorded webinar will be available on Friday, April 14th at hemophilia.org under the Events tab with all of our archived webinars. Also available in the Events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon. Have a wonderful week, and we will see you back here next week as we continue this series.